All right, I'll start with my introduction. I'm Brett Klein with Eisenhower Health in our public relations and community engagement. Thank you for joining us tonight, and both in person and on Zoom. As normal, this is our one of our final. We have one more next at the end of the month, but this is our Desert Orthopedic lecture series to kind of close out our season. We have Dr. David Friscia tonight, who will be talking, and he'll tell you about his topic, but we will be moving that forward momentarily. We are recording, as you well know. This will also be, once it's edited, it will be on our on our EisenhowerHealth.org website. It'll also be on Eisenhower Health YouTube channel. And all of our previous lectures, other ones from Dr. Friscia, as well as all other orthopedic, cardiovascular, cancer, and many, many, many others are on YouTube and in our calendar section of our website. And if you registered through our website, then I will automatically send you the link once we have it edited and out as well. So multiple different places to access it, but for going forward. And with that, I'm going to turn it over to Dr. Friscia, and we'll talk about innovations in total ankle replacement, the new gold standard. Dr. Friscia, it's all yours, sir.
Thank you. Thank everyone for attending. I know it's a hot spring afternoon, and it's a lot of other things to do, but this is a interesting topic, and something I have a great interest in, and have been following most of my career. And it's the exciting thing about orthopedics and what I do is that this has really evolved over the 35 years I've been in practice here at Eisenhower Medical Center. So the arthritis of the ankle is, occurs. It's not as common actually as hip and knee arthritis, but it can be debilitating. Obviously, we all walk and are active, and put a lot of pressure on our ankles. Ankle arthritis, in contrast to really maybe hip and knee arthritis, is usually post-traumatic. It's people break their ankles or have an accident, or some people who have ankle instability and have had recurrent sprains and injuries in the past. The ankle wears abnormally, and that predisposes you to it. But fortunately, the ankle arthritis is not as common as knee arthritis, and you'll see that in some of the numbers I show later. It can be inflammatory. People that have types of arthritis from inflammatory diseases like rheumatoid arthritis or lupus or psoriatic arthritis, that can attack any joint, and so it can be inflammatory. But it's usually from fractures or chronic sprains, and there's actually someone attending the lecture today mentioned that she had a fracture 20 years ago, and with pins in her ankle, and has a little pain now, but that's sometimes that's why we fix ankle fractures well, to lessen the risk of arthritis. And sometimes people do very well for years, and only after 20 or 30 years do they develop pain or arthritis that becomes symptomatic. So arthritis of the ankle is the initial treatment, like almost everything in orthopedics, is conservative. You treat it with non-steroidal anti-inflammatory medications like ibuprofen, Aleve, Advil, those type of things. Sometimes injections of cortisone help. Corticosteroid injections can help and give temporary relief. It doesn't cure it. Sometimes activity modifications helpful. You just, if you have a bad knee or a bad ankle, sometimes you just have to, modify your activities. You stop running. Maybe you don't play, go from singles tennis to doubles tennis, things like that. Sometimes braces and compression sleeves help, but this slide just shows an example of an ankle with, normally you see a joint space, you see, it's not air, but it's cartilage that you see. And in this case, there's none of that, because that's worn down, and it was damaged, and now the cartilage is gone, and it's bone on bone, and that gives people pain. Actually, going back to just the conservative treatments, there's other things that you may ask about, like stem cells, platelet-rich plasma, things like that. platelet-rich plasma is where we draw your blood, spit it down, and get growth factors and anti-inflammatory factors, and that can provide some temporary relief. Again, that doesn't generate new cartilage, but that can provide some temporary relief. Same with bone marrow, with stem cells. The big disadvantage of those treatments is that most of the time the results are variable and they're not covered by insurance because they're still considered experimental and not really reliable and not curative. And you'll see ads for ankles or knees or hips about stem cells or replacing. You put a stem cell in and you get all your cartilage back and all the joint comes back, and that just hasn't never been proven that it does not. It can provide some temporary anti-inflammatory relief, but stem cells do not regenerate cartilage per se. They have some good applications in a lot of areas in medicine. And, occasionally if there's a small defect, like in young people with ankle injuries, occasionally we can graft cartilage and help that. But with significant arthritis, that's not treatable. It's not treatable by that mechanism. The operative treatments for ankle arthritis, well, yeah, I just mentioned stem cell injections. Microfracture is where we do an arthroscopy and go in and try to make some holes in the bone to encourage your body to form fibrocartilage and maybe relieve some of the discomfort. Because the joint itself doesn't have, the ankle joint itself doesn't have pain fibers. The pain fibers are in the bone. And once the cartilage gets violated, it's in the bone. So if you can get fibrocartilage to kind of seal off the bone, sometimes that helps. There's not a good resurfacing. Some people have tried procedures where you clean out the joint and try to distract it, see if that relieves some of the pain. Sometimes if the ankle is really crooked, we can realign it by cutting the bone, trying to move pressure to a better area of cartilage. And they've even tried, although long-term haven't been super successful, in terms of what's called allograft joint replacement, where you actually take cadaver bone, you take the bone and the good cartilage from and cut out the arthritic bone and put that new bone in there and hope your body replaces that. Bone's living, and your body has to replace that and make that your own living bone, which takes a long time. And unfortunately, frequently it doesn't remodel fast enough, and it sometimes fractures and fails before it really has a chance for your body to take it, to integrate it. And that's kind of fallen out of favor. That's not commonly done at this point. Again, I talked about arthroscopy. So if people have spurs or loose bodies from old injuries, we can go on arthroscopically and clean those out. That can give some relief. The gold standard for years was ankle arthrodesis, which means ankle fusion. Taking out the arthritic bone, pushing the bones together, making it one bone. And that gets rid of the pain. The disadvantage is it's stiff. But for people, the stiffness is better than having the pain. And, the people can walk pretty well. Other joints in the ankle moves quite a bit in the foot and ankle, but other joints in the foot move. So there's 28 bones in the foot and ankle, and there's a lot of movement. So in other areas, so people accommodate, and people can do pretty well with an ankle fusion. And once it's fused, it can be fused forever, and people do pretty well with that, at least in the past. But again, it can put pressure on other joints, and people can develop arthritis. And then ankle arthroplasty, ankle replacement, is the other option, which I'm talking about today. When I started practice, ankle replacements were not done at all anymore, really. Joint replacements started in the United States in the late 1960s and the 70s, and then really kind of ballooned after that, because they're very successful. Hip and knee replacement, as you all either have had one or have friends that have had hip and knee replacements, and they're very common and do well. They've really been perfected over the years. Ankle replacements came out early on too, but the ankle joint is obviously a much smaller joint than the hip or the knee, and it just has did not tolerate with the initial designs, did not tolerate the forces and the pressure and the and things that that occurred. And the initial joint replacements were always cemented in with bone cement, and the cement would fragment, and it just wouldn't. The initial designs did not work. So the hip and knee replacements blossomed, but they stopped doing ankle replacements since the early ones did not do well. And then about 25 years ago, 25 years ago, new designs came out and had some better success rate, and those have since been perfected, and I'll go into that more in detail. But these slides just show slides of ankle arthritis, bone-on-bone arthritis, and ankle fusion with the two screws hold it, your body fuses it and makes it one bone, and then it gets rid of the pain. So that's an example of an ankle fusion or ankle arthrodesis. The ankle arthritis, again, is not as common as hip or knee arthritis, but there's probably about, some of these figures may be old, but there's, probably about 30,000 done a year now. I talked about the other options. Ankle replacements are much more common now. A few years ago, it was 6,000 a year. Now it's probably at least 10,000 a year in the United States. But that compares to knee replacements, where there's probably 1 million knee replacements done. So it's much lower numbers. But for people that have it, can be very successful and can relieve your symptoms, and most people can do very well. So again, an example of an ankle fusion with 3 screws that heals, and again, the ankle fusion puts pressure on other joints. People have pretty good function and good pain relief, and if someone has a significant severe deformity, if the ankle is really crooked for whatever reason, whether it's injury or from a neurologic problem, the ankle fusion can correct that and provide good correction and relief. The problem with ankle fusion is, by definition, you've lost motion. The ankle's stiff. People with ankle arthritis have lost some motion, but with an ankle fusion, you by definition, you have no motion in the ankle. Other joints move a little more, but that could put pressure on other joints. Like any surgery, there's no 100% guarantee. It's not. Sometimes the bones do not heal rapidly or do not heal, and it could be as high as 5 to 10% of people don't heal or require another surgery to get it healed. And like I said before, arthritis can develop in other joints in the foot. So so this is just an example of ankle fusion. The hardware has been removed, the ankle's fused, but the joint below, which is a subtalar joint, there's a lot, you have the ankle joint, which moves here. The subtalar joint is what helps you move side to side, and that joint can take a lot of pressure. And in this case, that joint's arthritic on X-ray. You can see on the the picture of the foot below just shows that this patient has an ankle fusion. But you can see their foot moves. So just because they have an ankle fusion doesn't mean the foot is rigid, that they can still move through the joints in the foot and have some motion of the forefoot and reasonable function. Again, an ankle fusion is durable. It's good for a lifetime, and it can treat a lot of complex problems, especially people that had infection or bad bone or neurologic problems. And again, people with previous infection, sometimes with multiple medical problems, might not be good candidates for an ankle replacement. Again, the worry, though, is that with an ankle fusion, people frequently develop arthritis in other joints, as pictured, the joint below, the subtalar joint. Most studies now have shown equivalent or sometimes even superior pain relief with an ankle replacement and better function. People are happy because they have motion, and that relieves other joints and and people, and we're all made, your joints are made to move, and you feel better with that. So that's been the advantage of a good ankle replacement. Initially, ankle replacements had a higher complication rate in terms of needing, this is an older slide now, but people needing additional surgeries or having a wound problem. The challenge of an ankle from the beginning was that, compared to your hip or your knee, there's not a lot of muscle or fat or soft tissue around the ankle. So your bones are very close to the skin, to the outside. And so with surgery and with there's a chance of, if there's a wound or a scab, there's a risk of infection and things like that. So that's always the challenge. But an ankle replacement, the advantages, it provides a less painful, stable foot. The range of motion is closer to normal. It's not always normal, but some people get excellent motion from it, and it decreases the risk for adjacent joints. The disadvantage are there can, there's no real reaction to the metal. The people, the rate of allergies to metal is extremely low, so body tolerates these metals very well. The polyethylene, the plastic liner that's in these joints, this polyethylene that helps smooth it here, that helps it glide like cartilage, is in years past, especially in the hip and the knee, this would wear. Like anything that keeps moving, it wears like your tire, and it would sometimes the wear debris would give you problems and loosening. Nowadays, they've found ways to make it more durable, so the polyethylene wear is not as big a problem, and they last much longer, and probably now 20, 30 years or more. So it's not been a problem with wear like it used to be in terms of that. The biggest challenge of an ankle replacement is that the bones of the ankle are small, and the talus bone is an interesting little bone because 70% of this bone called the talus is cartilage, and so its blood supply you don't get any blood through cartilage or through the joint. It all comes from the other attachments, and so if the bone loses circulation, it can fragment and collapse. It could be weak. It's a small bone to take a lot of weight, so you have to make sure that it's implanted well on that. But there's always a chance of that loosening or that bone collapsing. And like I said earlier, total joint replacement started in the late 60s, and then the early ankle replacements had a high failure rate, and so it's kind of abandoned for 20 or 30 years. But fortunately, with technology, we gained better designs and better techniques, and now like the title of the talk says, the ankle replacements have really become the gold standard in the last 20 years. And really even less than that, clearly now, probably 15, 20 years ago, sometimes some insurance companies called it experimental. They would hesitate to approve it, but now it's clearly they do well. Especially for some patients that have arthritis and that have had a fusion of the ankle and a fusion of other joints, the whole foot's really stiff. With so-called pan-talar fusion, and that could be really disabling. And so that's a great advantage for a motion segment of replacement. And to make the total ankle replacements work, the key was making good technology and reproducible bone cuts, replacing the articular surface, getting the rotation right. The ankle joint is basically a hinge joint. It's got ligaments. The challenge of the ankle too is that the ankle, sometimes with ankle arthritis, the ankle's crooked. It's, you either have a really flat foot or your foot turns in, and you've got to make sure the foot's aligned, otherwise the ankle will not wear normally. So that can make it a little more challenging. And in the United States now, there's several designs that are available. 25 years ago, there was just one that kind of started having more success, and now there's several that are out there that and it's kind of interesting because most of them have a design that they're similar. So fortunately, they've kind of come to agree that there's certain concepts that work and designs and quality. The Stryker Wright Medical in-bone, the first one is probably 70% of the market because they have a full continuum. The other ones are kind of similar. And that's the nice thing about orthopedics. They keep innovating and getting better and new designs. So this is just that picture is an example of what's called the in-bone. It's a Stryker prosthesis with a modular stem that helps us to gain stability and get a successful, stable ankle replacement. And these are other designs that are more resurfacing without a stem. This is a Salta Talaris with a different type of stem that's only partial. That's the old Agility. It's not put in anymore. Anyway, this was the one that came out a while ago that actually, I guess it was developed more than 25 years ago, and there's one guy that kind of put them in and evolved it and had some success for it. And then it was cleared by the FDA, and then other designs kind of evolved from that. This was another prosthesis that was used in Europe that came to the United States, the Star prosthesis. It's not as popular now, but it had some good early success. And then this was the in-bone, the one with the modular stem. So as you can see, there's lots of pieces to that, and it's kind of a complicated stem, but it really was revolutionary in terms of it can solve a lot of the problems, and that modular stem helped you fix deformities that you could not fix before. And again, the key was a good improved range of motion from an ankle fusion. So as I said, the designs of ankle replacements are much improved now. They used to, they may have a slightly higher complication rate than ankle fusion, only in that sometimes an ankle fusion can be done from a lateral approach versus the ankles usually guys to be done from an anterior approach. And the main complication is maybe a delayed wound healing or a scab, but the complication rates are really probably not significantly greater than ankle fusion now. But the main advantage is that you retain range of motion and stability of the ankle. And most people are very happy. I mean, it's always gratifying when patients come back. They've had pain for years. They have it. They come and they say, "This is life changing. I can play pickleball. I can hike. I can do things I couldn't do before." Because when you have arthritis and pain, you do restrict your activities, and even though it's not, you can live with that. We all want to be active and do what we enjoy. So that's gratifying when patients come back and have those good results. And again, the different designs, the in-bone has the stem, and it can correct significant deformities, and it also is for sometimes people's bone is not is a little soft. As we all get older, or we lose bone density, and if the bone's weak, any prosthesis can fail. And with a stem, that helps. So that's good for people with weaker bone. If people have good bone, sometimes we just can do the resurfacing prosthesis and not have to do the stem. So this prosthesis was very useful in that way. Again, the normal ankle is a semi-constrained joint. It's a hinge joint, and the ankle replacement just resurfaces the joint and to get good motion and remove the painful arthritic cartilage and bone. These are just intra-op pictures of actually that's an in-bone ankle replacement in place. The stem's obviously in the middle of the bone, so you don't see it. And with all these replacements, these components are not custom made. There's different sizes that we size to each patient. That's similar for each company. These are just x-rays showing an ankle replacement and the pictures of the design of it. This is just a case of a 58-year-old male with significant arthritis. And the patient has varus. That means the ankle turns inward. So the joint is off center, like a tire wearing eccentrically. And so in surgery, you resurface the joint and you can straighten it out, remove the arthritis, and they get a good result with much less pain. Another example of a woman who had a bad ankle fracture that may not, well, I'm not sure if the hardware was taken out or she never had surgery. In any case, it's bone-on-bone arthritis. Well, she did have multiple procedures in this case, and the hardware is now out. But again, with an ankle replacement, you resurface the joint, realign it, and it usually relieves the pain. So as you can see, this prosthesis has evolved over the last really 20 years in terms of initially a large jig to help put it in with a stem, and then 2010 they came up with a more resurfacing device rather than actually 2014 a resurfacing device, the Infinity. The stemmed component was improved over the years. And the other big innovation, which I'll show pictures of, is we don't do ankle replacements by robotics, but we do it by 3D printed cutting guides. So you get an image of the patient's ankle, and then you get a 3D printed guide made to their ankle and their anatomy that makes the procedure more precise. And I'll show pictures of that in a minute. So again, the Infinity to the left is the resurfacing prosthesis, which is adequate for most patients with more deformity. The in-bone has a stem and can correct bigger deformities or can accommodate for bone that's weaker. These can be cemented in for immediate stability, but most of the time we prefer giving the body a chance to grow in. You can see the surfaces are rough. They're and it's a material that the body does ingrow to these little pores, and so this porous coating is helpful to allow the body to ingrow, and that has been found to create the longest good long-term stability if you can have good bony ingrowth into those. So again, those two systems I've talked about, and they've got the pore coating. You have pegs for immediate stability, and then the body grows into the pore coating that's along the prosthesis. The system too is modular, so that if the plastic wears out, it can be replaced. If you need to revise it, you can keep one component and not replace both of them. So this is the cutting guides. This is the big innovation of the ankle replacements, kind of doing it with the latest technology, is these 3D printed custom guides are made and 3D printed to the patient specifically. So as this picture shows, you get a CT scan, the computer makes a 3D image of it, and then from that, they make this custom cutting guide that gets 3D printed that tells you where to put the initial pins and get the best alignment to align the ankle correctly so it works the best. And you can see this white material is a 3D printed guide. It's 3D printed, it's sterile, and they actually give you a model of the patient's bone. That's what you see at the back, and the guide at the front with the holes in it is the guide that fits over it. So it fits precisely and tells you where to pin it, and then from that you can make the appropriate cuts. This is again just an example showing the 3D printed white guide that's on the bone that's pinned, and then from that we could put on the guide. Before, we'd have to do various maneuvers to align it with X-ray, and it'd take longer, and it wasn't always as precise as using this technique. So it reduces surgical steps. It reduces the need for X-ray during the procedure. I mean, we use fluoroscopy X-ray during this procedure, but with this, this helps you. So you helps you align it, and it makes the procedure much more efficient, and it's very precise. And this is just an example of the plan they give you, that the patient gets a CT scan, it's sent to the company. The engineers provide this 3D these 3D images and a plan, and then the surgeon approves that, and then they send the custom cutting guides in time for the surgery. Um, and again, there's different designs of the components. Some have a flat cut, some have a curved cut to take less bone. We always want to conserve the patient's bone if possible, but have good ingrowth. And like I said before, the system for Stryker Wright has a continuum of different sizes and devices to accommodate, and even for revisions to accommodate most applications, and that's been useful. There's a learning curve to total ankle replacement, and here at Eisenhower we've done quite a few of them, I think it's the gold standard now, because patients do well. It's reproducible, just like hip and knee replacement. They keep on improving, but and in fact, this system is just about to go through it. They're improving it further with some additional. Most of it's going to be instrumentation, but that's coming out soon, and the systems keep on getting better and more reliable to improve patient outcomes, patient safety, and results. And we're also able to do it now that it's gotten so good and better. It used to be more selective about doing it with certain age groups. You don't want to do it in someone too young because you worry about it loosening, but then again, and someone too old because you worry about the bone quality and ingrowth. But with the better devices, we've extended that. And as for doing it, at what age to do it, it really depends on the patient's health. I mean, you don't, as you know, age is not a number. Age is a number, but it's patient's health can differ quite a bit. I mean, there's some people that are 85 years old that are extremely active, that if they have a severe arthritis, then their health is otherwise pretty good. They can have an ankle replacement. Well, there's some people in their 60s that they have too many medical problems, might not be good to have a big surgery. So, that's always a factor. So it's been shown that people's gait is better, gait functions better, and they have motion. They like that. It feels better. It creates a more normal ankle than an ankle fusion, and again, the satisfaction rate is very high now. It's not a particularly easy procedure, but it's been interesting to me because, again, when I started, we weren't doing these at all, and then I've kind of really been involved in the evolution of it. We participated in a multi-center study on one of these prostheses that was out. That's still going on. It's a 10-year follow-up. Because we're always doing more studies to follow these up, make sure they're doing well, and also do whatever we can to make it better. And as I said, there's definite benefits to gait. The ankle replacements last long now, and do much better. The results are predictable. They have an excellent 10-year survival rate, obviously the patients have to be selected carefully, and not everyone is a candidate, but ankle replacements or ankle arthritis is a lot of people have ankle injuries and ankle discomfort, and I think more and more people now are realizing they don't necessarily have to live with a painful extremity and a painful ankle, and they have a good option with an ankle fusion. With an ankle replacement and surgery. So anyway, that's just a quick summary of my experience with the ankle replacement and the evolution of it. It's exciting. I mean, that's why I still like doing surgery and working, because it's fun to help people and take care of people and to work with this technology that's gotten so much better and has evolved and and is really a state of the art and keeps on improving. So thank you. And if you have questions, I'll take questions from the audience or online. We can answer any questions about this or any other foot and ankle topics.
All right, for those in-house, just give me 1 second. For those online, you can also, we'll just be respectful. You can unmute and ask the question, I believe, and if not, you can also put it in the chat. What is the recovery period? I'm not sure exactly which procedure, but what is the general recovery period?
Sure. Yeah, that's a good question. Yeah, I guess I'd go over the whole thing. The surgery nowadays, like most orthopedic surgery, it can be done as an outpatient. It used to be under Medicare, it was classified as an inpatient only procedure because of the complexity, but now it can be done as an outpatient for healthy patients. And so don't necessarily have to have a hospital stay. The surgery is done, patients have a block before their surgery. The anesthesiologist numbs the extremity, so it blocks most of the severe pain that people have the first day or immediately after surgery. So hopefully you wake up after surgery with really no pain, and then the worst pain is blocked for at least the first day. You're asleep for the procedure, whether it be a spinal or a general anesthetic, but you're asleep for the procedure, but need less anesthesia because you have the block. After that, I put people in a splint for a couple days, but then after that, I put people in a soft compression dressing and a boot, no hard cast. And we want people to get it moving fairly soon. So there's no hard cast. You kind of have partial weight bearing for the first 2 to 3 weeks, depending on the bone quality. And then after that, can progress to full weight bearing with a soft dressing and a boot. And for an ankle replacement, generally you're in the boot for about 6 weeks. And then after that, if wounds healed and everything's doing fine, progress out of the boot and start physical therapy.
All right. A question from the audience here. We have another one online, but go ahead, front row.
Sure. Yeah, there's actually 3. You probably maybe they overlapped on that picture, but
if we can repeat the question, that'll help for the Zoom audience.
Sure. Yeah, he asked on the Infinity. I'm trying to get back to the picture of it. There's 2 small prongs. He said there's actually 3. 2. They're in slightly different planes, but I'll get to the picture. But anyway, there's 3 prongs. So the purpose of that is that the pegs or prongs, when you impact it, you make a hole in the bone, you drill that and impact it, and that provides some initial immediate stability of the prosthesis, and you don't want it to be able to translate back or forth. And then meanwhile, the body's ingrowing into the these are the pegs here, and there's 1 long one in the back and 2 short ones, and there's 1 long one in the front, and then 2 shorter ones that overlap each other here. And in any case, those stabilize it from going back or forward, and then the bone grows into the mesh, the pore coat that's on the top of the prosthesis. The prongs do not have a pore coat, but they provide the immediate stability.
All right. Another question. 1 more question, a couple more here. If someone needs bilateral ankle replacement, how close together can they be done?
Yeah, it's a big surgery, so we don't do them at the same time. Occasionally there's some surgeons that do bilateral knee replacements, but most prefer not doing that. But yeah, we don't do bilateral ankle replacements. In terms of the spacing, you want things completely healed in therapy. So, the minimum would be 3 months because you want it fully healed and want to have done some physical therapy. But I'd say space them at least 3 to 4 months apart.
Great. Another question from the audience in person? Go ahead.
Yes. Right. Yeah. Well, with a ankle fracture, you break the ankle. It sounds like you had what's called a trimolar fracture, broke the ankle on both sides of the back, and so it displaces. And the ankle joint, it's a small joint, and it's been shown just a millimeter or 2 variation can wear the cartilage and give you arthritis. So that's why we fix ankles commonly and with plates and screws to realign it. Now, the plates and screws are not to themselves do not prevent the arthritis. It's that we're putting the bones back where they belong. So the joint wants to be back where it belongs. The cartilage, like anything, it's like a uneven sidewalk with a crack. You want it smooth. You want it flat. You want it the minimal, the least resistance possible. So by fixing it, you put the cartilage, the bone back where it belongs, and your body has to heal it back. There may be some from the trauma and the impact or whatever, how you broke your ankle, some permanent damage to the cartilage or bone that can over the years cause loss of the cartilage and bone and progress to arthritis. But the best chance of preventing that is having the ankle fixed well early on. And some people with have their ankle fixed and never go to arthritis. But others do because there's still other damage. We can't fix all the cartilage, the cartilage is contused or bruised and other bone damage that doesn't fix it. The question about the metal, the body, modern metals, the body tolerates very well. We use stainless steel, titanium, the metals, the body does, very few people are allergic to it or reject it. Like you said, usually we don't need to remove the hardware unless for some reason it's symptomatic. The ankle is thin. Obviously, the skin's thin around the ankle, and as the swelling goes down, some people feel the plate on the outer bone. Your ankles are pretty bony, and the modern plates and screws are pretty low profile now and thin, fortunately. So they're usually not that easily. You usually don't feel them, or they're not that symptomatic. But if you can feel it bothers you, we do take them out. But like I always tell people, it's another surgery to take them out. So it doesn't have to be taken out for any reason. It doesn't usually have to be taken out unless you can feel it, or the other reason to take it out, if after a bad ankle fracture, sometimes people have an open wound, or if you get an infection. Infection's hard to get rid of when there's metal in place because the bacteria can form a coat and hide on the metal. And so in those cases, sometimes we have to get the metal out to be able to treat any infection and get a wound or an infection healed. So, but you're right, metal can stay in forever usually. The body, sometimes when people are young, sometimes these plates and screws can be covered with bone. The bone grows over the plates. It's hard to find it sometimes, except by x-ray. Well, sometimes, especially in younger people, like we operate on kids frequently. They're so active forming bone and healing things. Sometimes the bone, the plates get covered with bone. In adults, usually not that much extra bone formation over the plate, and we don't usually want that or intend that, but that can happen. But the body, the body reacts very well to the metal in general, and doesn't reject it, and again doesn't. You don't grow into the plate and screws, but sometimes fibrous tissue or bone grows around the holes and things like that. But the body does adapt to it and accommodate it well. Again, the hardware is just there to hold the bone. Your body's got to heal the fracture. So if sometimes the plates can break if the bone doesn't heal in time, because if you keep on stressing the metal, it can eventually break if people are putting weight too early or the bone's not healed adequately. So that can happen too, because your body heals the bone and the joint, and we're just helping it in fixing fractures to hold it in the right position so it has a chance to do that.
Exercise?
Yeah, that's a good question. Yeah, I mean, osteopenia, osteoporosis is extremely common. It starts. I mean, weight bearing exercises and resistance exercises are good. So I think it's always good to be taking adequate calcium and vitamin D. So a reasonable diet, taking calcium and vitamin D, obviously, for Men are at much less risk, but women have a higher proportion of osteoporosis. So, most women have a bone density test. If the bone density is excessively low, there's a lot of medications now that can treat it and help increase it. So you have less risk of a fracture, because obviously, you don't want to, the wrist fractures and hip fractures are common as people get older, and hip fractures can be devastating for someone. So we want to try to avoid those. So that's why there's some of these treatments that are improved. But I think there's good evidence that certainly a good diet and weight-bearing exercises. And I think for younger people, it's important to be eating a good diet, and it starts from I think when you're young, you build up your bone density, and you're from being a teenager to your 30s, and then it's all downhill from there. So sometimes for especially for the thing to emphasize is if you have children or grandchildren, make sure they're the girls in the past, sometimes girls were dieting, not eating, not drinking milk, not eating a good diet. And, you just need to make sure you're getting your calcium from something and building up your bone density to a maximum, because it keeps going down, and, we should have it up at the beginning. But weight bearing is important, because you can even see on patients on x-ray, which is not a precise on bone density, but if someone's even in a cast or non-weight bearing for a few months, you can see how much bone density gets lost in that leg. So weight bearing and resistance, and I think now even there's a lot of senior programs for resistance training, for weight training, to really get some. You're not doing heavy weights, but just reasonable resistance weight training is good for your bone density.
All right, a couple more questions online here. What are typical ROM post? I think it is ROM/post surgery for PF and DF. Does that make sense?
Oh, yeah. I think that it sounds like a physical therapist asking the question or something, but it's a range of ROM. The question is, what is ROM is range of motion and plantar flexion, dorsiflexion. So that's the motion of the ankle dorsiflexion moving up, plantar flexion moving down. And I mean, for a normal ankle, people vary. There's some people have stiff ankles to start with. There's some patients I see that you can barely get their ankle above neutral to 5 degrees. But normal range of motion is at least 20 degrees of dorsiflexion, probably 50 to 60 degrees of plantar flexion. And after an ankle replacement, it varies quite a bit. Some have near normal motion, some have a little stiffness. It kind of depends where people started at before surgery too. Sometimes people have ankle arthritis and a very stiff ankle and hardly any motion. And, if they're that stiff, it's much harder to get full motion. But I would say the average is 5 to 10 degrees of dorsiflexion, which is comfortable and functional, and probably 35 to 45 degrees of plantar flexion going down.
All right. And then follow-up question on that is how many ankle replacements have you performed?
Yeah, I've performed hundreds of them. I think I'm one of the highest volume people in Southern California, but we probably do about 50 a year now, and which is a high volume for ankle replacements.
Another one, a couple more here. Typically, how long before you can drive after a right ankle replacement?
Yeah, you can drive once you're out of the boot and the ankle's strong and comfortable. You can drive. So when you have surgery on the right side with any procedure that you're until you're out of a boot or device, you shouldn't be driving. There's some people that try to do it, and I strongly discourage that, because that's not safe. So you don't drive with a boot. But so probably at 6 weeks would be the earliest, but say at 6 to 8 weeks, I think people should be comfortable driving.
All right. I think this is from the same, maybe a PT. What if other joints are arthritic in addition to talocrural joint?
Yeah.
Can't say that, right?
Yeah. The subtalar joint or the talonavicular joint, that's a good question, because there's other associated arthritis. And, first of all, we've got to make sure we know where the pain's coming from. Because sometimes people might have some mild arthritis in the ankle, but really the ankle arthritis is from the subtalar joint or the talocalcaneal joint or the talonavicular joint. So if these other joints are causing the arthritis, you deal with those. Those other joints are not replaced. The only way to fix those other joints is to fuse those, and people do well with that. And so, and so the answer is that we either, if there's significant arthritis in other joint, like say that for subtalar arthritis, we either fuse the subtalar joint at the same time as the ankle replacement or stage it. It depends on the patient's deformity and age and different indications, but sometimes, for instance, if they had a really crooked foot with arthritis in the subtalar joint, the calcaneocuboid joint, the talonavicular joint, and a really crooked hindfoot, you would probably do what's called a triple arthrodesis, fuse the hindfoot first and get that healed so you have a stable hindfoot, and then come back later once that's all fully healed and do a good ankle replacement. Obviously it's good to do things all at once. So if someone just has some arthritis in this subtalar joint, I can sometimes fuse that through a small incision and in conjunction with the ankle replacement.
All right. We have another one online, but do we have other questions in the room here before I jump back to online? All right. Another one is, to think about a question in the room. This is from a competitive golfer. Will I be able to play and practice every day without fear of damaging the replaced joint?
Yes. Yes. I mean, once it's all healed, give it at least 2 months, after surgery, that you're out of the boot, you've done some therapy, the ankle's strong again. So at least after 2 to 3 months, you should be able to play competitively. And golf's an ideal sport because it's not an impact sport. You're not running and jumping on it. You can do plenty of walking, and should be able to, after the ankle replacement, people should be able to get back to their activities, walking, hiking, golf, sometimes even doubles tennis. Pickleball is a lot of strain on it, but pickleball's always, usually doubles, and doubles tennis or doubles pickleball is probably fine. But certainly golf is ideal and should be able to get back to that. The ankle should be stable and the motion should be fine for that.
All right. In the room, more questions from the audience?
Yeah, it's a good question. It depends on the deformity and how much you have to straighten out and things like that. But for the, I'd say it takes on the average, it takes about 2 hours of surgery time. That doesn't account the anesthesia time for the patient to sleep and getting up. But in terms of the operative time is about 2 hours for the average replacement. If it's a complex, but sometimes, like say people that have had fractures, we have to go in there and sometimes take out old screws and hardware and things like that. Or if it have to straighten out an ankle or do ligament releases, it can be longer if it's a complicated, ankle with more deformity. But I'd say the average is about 2 hours.
All right. Whoops. Yep. And no more questions currently online. Anything else in the room here?
Yep. Yeah, obviously everyone's different. I mean, you're talking about you had the boot on because you had not an ankle replacement, but an ankle fracture. So with a bad ankle fracture, it can take a while to recover. Generally, we try to get people out of a cast or a boot when the bones are healed, and depending, that can take, depending on your age, anywhere from 4 weeks to 4 months. But most people are pretty well healed at 6 to 8 weeks, and we try to get them out of the boot and moving and into physical therapy. But sometimes it takes longer, and obviously you're unsure about it. It feels weak, and but the good thing is now with fractures, we've gotten better at that too. That the devices are better. That and yes.
Important for the recovery.
Yeah, therapy is helpful, and we try to fix things stable and try to get people weight bearing sooner rather than later. I mean, I think in the past people weren't as confident in some of the hardware, so we keep people off it. But keeping your weight off it also makes you weaker and leads to more loss of bone stock and things like that. So nowadays, sometimes with the better surgical techniques and better hardware, people can weight bear and get it moving sooner. That's another advantage of surgery. If sometimes if there's a question, you can treat some fractures in a cast, but having a cast on for 6 or 8 weeks is hard. And with surgery, sometimes fixing it this way, you can get out of a cast and get it moving after a few weeks, and just wear a boot, and that's I think an advantage to a lot of people. Yeah, these injuries can be debilitating. So that's unfortunately, I think the treatment ankle fracture has gotten better, but it is a process, and an ankle fracture or ankle arthritis, it can be disabling.
All right, another question from online: is there a torn? If there is a torn peroneal tendon in addition to the need for replacement, how does that complicate things?
Yeah, a torn peroneal tendon. The peroneal tendons there's 2 tendons on the outside of the ankle that go behind the fibular bone that help stabilize the lateral ankle and move your foot outward. And like all tendons, as we go over, there's wear and tear. So there's sometimes in older people we see lots of tears, partial tears of the peroneal tendons. They're not always symptomatic. I guess it just depends on the peroneal tendon pathology. Doesn't complicate it that much, except unless there's instability. And if there's with an ankle replacement, generally we're going from the front of the ankle, repairing it. We don't generally look at the peroneal tendons unless we're going on the fibular bone to remove screws or remove hardware. But if the patient had ankle arthritis and perhaps had a peroneal tendon pathology from an MRI, we saw that there was a large tear or split tear or some dysfunction. We could obviously repair that at the same time, because we repair peroneal tendons all the time surgically, with either anchors or suture to reconstruct them or repair them.
All right. We are almost at time, and that's all the questions we have currently. Anything else internally here, or Dr. Friscia, any final comments from you, sir?
No, I think they're all excellent questions, and we covered a lot on this topic. It's again an exciting field that again, it keeps me going, and I like doing these procedures, and it's incredible the progress and technology and improvement we've made over the last 30 years in ankle replacement.
All right. Well, thank you everyone for attending. And as I mentioned, this had been recorded. It will be edited, and it will be back online and sent out to everybody within the next 2 weeks. Dr. Friscia, thank you very much. Everybody have a wonderful evening.